All right, good evening, everyone. We have about 20 participants, so we're going to get started. Welcome to ACHQC Core Insights, December edition. Tonight, we're going to talk about minimally invasive ventral hernia repair. My name is Megan. I'm the Abdominal Wall Reconstruction Fellow at Cleveland Clinic currently. I'm going to present some papers and some research, some literature, and then we're going to have Dr. Aldo Fafaj, who is a PGY5 chief resident from Cleveland Clinic, present a few cases. Our moderator tonight is Dr. Rana Higgins. She is a bariatric general and hernia surgeon from Wisconsin. So feel free to post some questions in the chat box. I'm going to kind of fly through my presentation, and then at the end, we'll have a small period of time for questions, and then we'll go into the cases, which are going to be much more interactive. So I just want to confirm everyone can see my slide.
Yes.
Okay, perfect. Thank you. All right, so I decided to title this talk, Long Live IPOM. And I did that because, the treatment of small to medium-sized ventral hernia repairs over the last few years, even since I started training, which was not that many years ago, has changed a lot. We really moved away from intraperitoneal onlay mesh towards the enhanced view, totally extraperitoneal, or ETEP approach. And really, when you dig into the literature around this, there's not a clear reason why, except for the push towards getting mesh outside of the intraperitoneal cavity and into the retromuscular space. And it's interesting that if you look at this paper from JAMA in 2020 on trends in robotic surgery, that the number of robotic ventral hernia repairs has increased extremely at the same time as ETEP has gone up a lot. So I think that the robot has been a bit of a facilitator for the ETEP, and there's not much data to back it. So I wanted to focus tonight almost on all these bad things people say about IPOM, which after reading the data, really they're all myths. So we're going to talk about 6 different things. The first one is that traumatic fixation, which obviously you need to do to get mesh fixated in peritoneal cavity, is painful. The second one we're going to talk about is closing the defect laparoscopically. It's challenging. The third one we're going to talk about is that an IPOM is expensive. Coated mesh and tackers really drive up the cost. The fourth one is that intraperitoneal mesh causes problems. The fifth one is that you need the robot to do an IPOM. And the sixth one is that ETEP is better. So tonight we're going to bust the myths. So let's start with the first one. Traumatic fixation is painful. So there's actually level 1 randomized evidence to support that this is actually not the case. I wanted to start out with the WOW trial. This is the with or without sutures randomized control trial published in 2013. It had 76 patients. The hernia size was 45 centimeters squared, or about 6 to 7 centimeters. They looked at double crown fixation with tacks versus transfascial sutures and a single crown. Their primary outcome was pain measured by the VAS scale. And what they found was that the double crown was less painful than transfascials. So that's kind of obvious. We all sort of thought that. Interestingly, their recurrence at 1 year was exactly the same. So let's take transfascials out of the equation. Sorry, this is their, what they thought in this trial was kind of interesting was that as you increase the number of tacks on the mesh, you increase the interface between the mesh and the abdominal wall. And that helps the mesh not only stay flat, but also ingrow, and therefore decrease your recurrence rate. So let's take transfascials sort of out of the equation now. The next trial I wanted to bring up was the Prove It trial. This is published in 2021, and it looked at a robotic IPOM where you suture the fascial defect closed and you suture the mesh into place. And you compare that to the laparoscopic equivalent where the defect was closed using the Carter-Thompson suture passer. And then the mesh was secured with 4 transfascial sutures and a double crown. And interestingly, they found absolutely no difference in pain on post-op day 0, 1, 7, and 30. They used the NRS 11 and the PROMIS 3A scale. So you could argue, okay, well, they used a different pain scale than the WOW trial, and still suturing the mesh to the peritoneal cavity is still traumatic fixation. So the next tiebreaker trial I wanted to introduce was the REVEAL trial. It's published this year by Dr. Petro from Cleveland Clinic. It was a 100-patient randomized trial that looked at robotic IPOM. So again, suturing the defect closed, suturing the mesh, and it compared it to robotic ETEP, which is absolutely no traumatic fixation at all. And again, they found absolutely no difference in pain on post-op day 0, 1, 7, and 30. And to further that, there was no difference in the amount of opioids that these patients took. So with that, I can officially say that this myth is busted. So let's move on to the second one. Defect closure is challenging. So first of all, why do we close these defects? Well, we want to prevent this so-called mesh eventuation or pseudo recurrence. This is when you bridge these fascial defects, you worry about the mesh sort of being sucked up into the hernia sac and creating what looks like essentially a new hernia. This has been very well studied. There was a meta-analysis in 2016, which included over 3,600 patients that compared closure of the fascial defects versus bridge. And they looked at these adverse hernia site events, of which mesh eventuation and recurrence were included, and they found a significantly lower mesh eventuation and recurrence rate when you close the defect. This was followed up with a randomized controlled trial that compared closure of the fascial defect versus not in umbilical hernias. This was done in 80 patients, and the defect size was quite small. Despite that, the recurrence rate was significantly lower, 7% versus 19%, when you close the defects. So could argue that if you're doing this laparoscopically, suturing the abdominal wall laparoscopically is challenging, but it is important. So this was a randomized trial published by Dr. Liang's group in Texas, and they looked at 129 patients with 4-centimeter hernias, closing the fascia primarily versus a bridge with both with intraperitoneal onlay mesh. They used the Carter-Thompson suture passer to close their fascial defects. And what they found was that when they did this, there was an improved quality of life using the modified activity assessment scale, which is a hernia-specific quality of life survey that's previously been validated. And you can see the huge difference between the two groups, 41 in the closed groups versus 29 in the bridged group. So it's important. It's important to get these defects closed, even for these small-sized hernias. If you're not a fan of this Carter-Thompson fascial closure device and piercing several holes in the patient's abdominal wall, there's an alternative. So there was this randomized control trial that compared laparoscopic IPOM versus a hybrid approach. So the hybrid approach includes making a small incision on top of the hernia defect, resecting the hernia sac, putting the mesh in through that defect, and then going laparoscopically and tacking that. So you can say, well, now these patients have an incision, they're probably going to have more pain, they're going to have higher wound infection rate, but that's not true at all. This study looked at 194 patients. The hernia defects were 2 to 7 centimeters. Like I said, the hybrid patients had a mini laparotomy, which facilitated open fascial closure. And that was compared to a lap bridged IPOM. And they found no differences in recurrence, SSIs, or quality of life. There was a small increased amount of pain in the hybrid group on postoperative day 1, which is very obvious, but that did not translate into long-term poor outcomes. So with that, I can officially say that that myth is busted. Third, so IPOM is more expensive. A lot of times people think that using a coated mesh and 1, if not 2 tackers really drives up the price. Well, the one study that really contradicts this is the REVEAL trial, the study I've already introduced. It compared robotic IPOM versus robotic ETEP, and you can see the difference in costs is very similar. Actually, the ETEP was more expensive, and what they argued was that the amount of money that you save in using a cheap piece of mesh for ETEP is actually offset by the increase in operative time and the increased use of different robotic equipment. So let's take the robot off the table though, and let's say you are doing this laparoscopically. There was a trial that was conducted in India that compared laparoscopic ETEP versus laparoscopic IPOM. And interestingly, this is a 60-patient randomized control trial published this year. And what they found was that the IPOM was more expensive and significantly more expensive. They measured their cost in Indian rupees. And you can see that it was about 2.4 times more expensive to do an IPOM with coated mesh and tackers than it was to do the ETEP. And despite this being more expensive, the operative time was significantly less in the IPOM group compared to the ETEP. So I'm not completely sure where they got all their cost values from. I asked Dr. Petro what he thought about this, and he said that in India, he felt that the mesh maybe was more expensive. So the dual mesh really likely drove up the cost in this trial. But since most surgeons in the US are doing this robotically, I can still say that this trial or this myth is busted. I'm not sure what's happening here. Busted. All right, next myth. So intraperitoneal mesh causes problems. This was sort of like the most alarming thing to look up in the literature, and the thing that really you can hardly find anything about. There is one study that was published in JAMA. This was a massive study using the Netherlands hernia registry. It included over 3,200 patients. And what they found was that over the years, the complications related to mesh increased, but the number was so small at 5 years, there was only 5.6% of patients that had a mesh-related complication. And when they broke down the different types of mesh, they found that the coated polypropylene mesh had fewer complications than the uncoated. And when they looked at different mesh positions within the abdominal wall, there was no statistically significant differences between those positions and complications. There was another retrospective study published by Gray et al. It included over 1,100 patients. And what they found was that if you have to go back into an abdomen where there is a piece of intraperitoneal mesh, there was an increased risk of having an enterotomy or unplanned bowel resection. And that was 20% of patients versus 5%. So that's really the only good piece of evidence to show that there is sort of harmful effects from having an intraperitoneal piece of mesh. That being said, we've all seen the complications of intraperitoneal mesh. They're just rare. We've all seen small bowel obstructions or large bowel obstructions caused by various loops of bowel just being absolutely densely adhered to this intraperitoneal mesh. Having to take these patients to the operating room can be quite challenging. I'm sure there's a few of us who have done a colonoscopy and seen mesh erode into the lumen of a bowel. And finally, we've all resected pieces of bowel from enterocutaneous fistulas caused by these intraperitoneal mesh. Currently, right now in the literature, there's sort of not good evidence on this. It would be interesting to look at a study to see if someone could evaluate the rates or the numbers of these very harmful consequences. Equally said, though, there is rare, again, but devastating complications of ETEP or getting that mesh in the retromuscular plane. In the REVEAL trial, there was only one piece of mesh that had to come out, and that was caused by a bowel injury through the posterior rectus sheath. When you're in that ETEP plane, you can't see inside of the abdominal cavity, and if you burn on the posterior rectus sheath, you have no idea what you're burning beneath it. Also, you can get a posterior rectus sheath breakdown. This is a CT scan that I got off the International Hernia Collaboration website. And you can see the posterior rectus sheath has just come away, has dropped down, split in half, likely due to too much tension. And there's several bowel loops that have herniated up there, causing an intraparietal hernia and a small bowel obstruction. This is a very devastating complication for these patients that have to be taken back to the operating room. And sometimes this bowel can be very adherent to this uncoated mesh that's in this retrorectus pocket. And then next, injury to the linea semilunaris. It's key to know your anatomy when you're doing these retromuscular dissections. This is a picture from a paper published by Dr. Igor Belyansky about the landmarks. You should be able to identify the neurovascular bundles and know where the linea semilunaris is so that you don't just burn through it and cause these terrible bilateral linea semilunaris injuries and lateral hernias. And lastly, the one sort of big downfall of ETEP is that these generally are being done for small 2.5 centimeter umbilical hernias. And now you've sort of completely carpeted and destroyed the retromuscular plane for such a small hernia. Just seems like overkill. And if that patient has an operation down the line and then needs another hernia repair, you've added a level of complexity to that case. So back to our myths. So the next myth, so robotic IPOM is better than laparoscopic. Do you need the robot to do an IPOM? And really, there's 2 trials that are excellently conducted that show that you do not. Dr. Liang published a 124 patient randomized trial with 90-day follow-up comparing laparoscopic IPOM versus, and that included the transfascial sutures with a double crown versus the robotic IPOM, where everything was sutured closed essentially. And he found no difference in length of stay, conversions, readmissions, wound complications, pain, quality of life. The only thing really that was different was the robot took much longer, 144 minutes compared to 77, and was significantly more expensive. So about $3,000 more expensive. He did also publish his 1-year outcomes, which showed the recurrence rate between these 2 operations is exactly the same. So really the extra cost can't be justified. This was further corroborated by the Prove It trial, which compared laparoscopic IPOM versus robotic IPOM. And again, they found no difference in length of stay, quality of life complications, but they did find that the robot took significantly more time, increased cost, and they also published their long-term outcomes, which showed no difference in recurrence. So again, myth busted. All right, the last myth, ETEP is better. I think the ETEP is a very interesting operation. I really like doing it, but I can't sit here tonight and tell you that it's better. It's not arguably any worse than an IPOM, but it's definitely not better. So the REVEAL trial, again, 100 patients, really showed that there was no difference in surgical site infections, occurrences. Actually, the Robo ETEP had increased seromas. I know this doesn't always translate into something clinically significant. They also looked at a very interesting outcome. They measured surgeon frustration and performance in the operating room, and what they found was that the ETEP was associated with a higher mental load, amount of effort spent in the operating room, and the amount of frustration. And their 30-day, this was just a 30-day trial, found that their quality of life is the exact same between these 2 patients. There's another study that was published in this is the Indian trial. It was again a 60-patient randomized control trial. And interestingly, when they did this laparoscopically, they found that there was improved pain at 6 hours, 24 hours, 1 week, and 6 weeks. They also noted that the IPOMs had higher rate of seromas, but there was no difference in overall infection rates, and that quality of life improved in both patients. What they did also find was that the ETEP patients returned to daily activities quicker than the IPOM patients. It was just a short-term follow-up trial, which showed no difference at 3 months. So we'll be expecting their long-term outcomes shortly. The one thing is that, like I said before, most ETEPs in the United States are being done robotically. So again, it's failed to show an improvement. So when is ETEP useful? There are certain times when I do think that ETEP does have a benefit, and that's particularly when there's multiple or Swiss cheese defects. And that's because you can sort of access both of the defects through the same plane and just cover both with a large piece of mesh. I guess the contrary argument to that is that now you're using a huge piece of mesh to close two very small defects. Next, the sort of hernia defects at the extreme end, so right underneath the xiphoid or right above the pubis, near those bony prominences. I find ETEPs kind of helpful for those as well. You can do a superior inferior dock and access them very nicely. Next is if you have sort of ventral hernia and at the same time as an inguinal hernia, again, same plane, same access, same cuts, you can access both. Also, if you have recurrence after IPOM, the IPOM mesh sort of acts as like a great posterior rectus sheath. It's quite easy to get into that plane. So that's another benefit of it. And then finally, in a patient where you would want to have mesh outside of the peritoneal cavity, like inflammatory bowel disease, ETEP could also be useful. This is a very short video. I'm going to play. This is a video of how we do an IPOM plus this hybrid approach at Cleveland Clinic. So we start with a skin incision and we fully dissect out the hernia sac circumferentially. And then completely remove the sac and any sort of fatty contents that it contains until we can get two cokers on the edges of the fascia. We measure the fascial defect. We then put in our closing sutures. So we put in figure of 8 Surgilon sutures. These are the sutures that we use at the end of the case to close the hernia defect, but these are also the sutures that are used to hold the 12mm trocar into place. We put this 12mm trocar right through hernia defect and secure it into place with those sutures. We then insert our ports. We usually use 3 ports for this, for the lap IPOM. We take down any adhesions if we need to. In this case, they were very favorable. We make sure that we have enough clear abdominal wall for our mesh. One important part is to make sure that this trocar is sort of pulled back as far as you can. Take down the falciform ligament. We don't really bother taking down the preperitoneal fat along the top of the wall of the abdominal wall. I don't really think that makes a difference. And then the mesh. So for the mesh, you put a single suture in the center of the mesh and you leave one of the tails long. This allows you to sort of pull it up and anchor it to the anterior abdominal wall. The mesh is rolled up like a scroll with the help of your assistant. It's rolled up like this because it's much easier to deploy when you only have to unroll it sort of halfway. The mesh is put in through the trocar so it never touches the skin. Use your central suture on the mesh to sort of pull it up against the abdominal wall. You can see that it's already sort of deployed. Straighten it out with your instruments and then pull back the trocar. And then the mesh is tacked into place. We always start with tacking it at cardinal positions, 3, 6, 9, and 12. And that sort of helps straighten out the mesh and prevents any wrinkles while tacking it in between. So again, tacking at 3, 6, 9, and 12. And you'll notice that the angle that the tacker is coming in at constantly changes, constantly moving it around the patient so that you can get at a 90-degree angle to the abdominal wall when you're using the tacker. So it's never sort of awkward when you're placing these tacks. So we start with our outer crown, single outer crown of tacks. Once that's complete, we move to our inner crown, our second or double crown of tacks. Usually it takes more than one tacker for this size of mesh. I think this is a 15-centimeter circular mesh. And that's that. Then we remove our trocar and tie down our fascial closing figure of 8 sutures. So the one big benefit of the hybrid approach is that you have the ability to close the fascia primarily from an open position. I think that's actually something that's really key because you can see the edges of the fascia. You're not sort of guessing like you are when you're doing this minimally invasively. So after they're all tied down, I'll just show you the final product here. That's it. Those cases generally take 20-25 minutes, which is, I think, an appropriate amount of time that you should be spending on a 2.5-3 centimeter primary umbilical hernia. So that brings me to my conclusion slide. So on the left is all our myths, and on the right is sort of all our truths. So traumatic fixation really is not painful. Defect closure, especially when you use the hybrid approach, is not challenging. The cost of the mesh and the tacker is offset by the increase in operative time and the amount of robotic instruments used. Intraperitoneal mesh does cause problems, but it's rare, and until there's sort of better published data, there's no evidence that it causes any more problems than retromuscular mesh. You don't need a robot to do an IPOM, and ETEP at this point has not been proven to be better. So thank you. Dr. Higgins, I don't know if you have any comments.
No, I think that was great. I guess as a bariatric surgeon, I have a lot of obese patients who have hernia. So what did you find in the literature? What are your thoughts about IPOMs in obese patients, specifically lap versus robotic versus doing an ETEP? I mean, has this been looked at specifically in obese patient populations, or what's the average BMI of the patients that you've been seen in the literature? Just because there's a lot of unique challenges to doing hernia repairs in obese patients. So just curious what your thoughts were about that.
I'm pretty sure the average BMI in both the Reveal and the Prove It trial was 32. That's a little bit lower than I would say the average that we see in our clinic. But I didn't specifically dig through the literature for obese patients. So I'm not actually 100% sure. We're doing a study right now looking at like retromuscular repairs in obese patients, and we haven't really found that it's made that big of a difference. But I actually think doing a minimally invasive IPOM in an obese patient is beneficial in terms of a wound complication perspective. And, if you're going to fix a 2 centimeter umbilical hernia, an IPOM is just such a great operation. And even if they recur, you have like everything left on the table.
I would add, it's a great question about the obesity. I mean, why these are tough things to answer is the reality is I'm sure there's retrospective studies that are kind of super selective about obese people that say that X, Y, and Z is better. But I think like the truth is obese patients are harder to fix no matter what you do. Like if you're really just being honest about it, they're hard. And there's a lot of things going against you. And I think especially being a bariatric surgeon, you would agree, like it's better to get an obese patient to lose weight before you fix their hernia. Like I don't think any of us argue that. But then there's a lot of obese people that don't want bariatric surgery, and we're left with this. So I would just stress that I think a minimally invasive lap robotic, whatever, in an obese patient, if it's a small defect in an obese patient, they're probably all equal. If it's a big defect, meaning like 8 to 10 centimeters in an obese patient, you're probably in trouble no matter what you do. Because they're all going to have a pretty high failure rate because those are just really, really hard hernias. So I have a question for everybody. because I think like the timeliness of this talk, I mean, like we set the schedule up a year in advance. But I'm curious, particularly for some of the attendings on the call. So this happened in the backdrop of CMS releasing their new reimbursement for hernia surgery. And, you know, I mean, unless you're living under a rock, you must now know that we are all going to get paid less for fixing smaller hernias. And I think, to me, that was a shot across the bow from the people paying us to do our job to rein in the nonsense. And so I think most surgeons out there are just trying to do what they think is best for people. And I think like the prevailing winds are everybody needs an E-tep, get the mesh outside the peritoneal cavity. And that's doubling OR time, you know, causing surgeon stress and whatnot. So I'm just curious how are some people going to interpret this? You know, if it takes you 2 hours to do a robotic E-tep and 30 minutes to do a lap IPOP, and the outcomes are equivalent for the patients, I mean, you can't prove one or the other, who is going to continue doing robotic E-teps and then just complain that we're not getting paid enough, but keep doing the nonsense? So I'm just curious, has that changed anybody's perspective on how long you're willing to spend doing a 3-centimeter hernia when you're basically not getting paid to do it? Rana, what do you think? How does this affect you?
Yeah, I mean, I don't really do ETEPs. Matt has started to venture into the ETEP space. I do mostly robotic IPOMs. My average BMI patient is definitely over 35. You know, we have a lot of trouble with bariatric surgery coverage in Wisconsin, but I agree. I mean, I think with those guidelines, you know, you have these small umbilical hernias that Megan was talking about. If they're less than 3 centimeters, then, you know, there's no difference whether you exhaust yourself doing a robotic E-tep versus an IPOM versus, you know, so I think it will challenge a lot of us in terms of thinking of how we're going to approach it, because then you can't be as productive throughout the day. You can't do as many cases throughout the day if you're spending the time doing a robotic E-tep. And as we all know, you have to do a certain number of cases to get through that learning curve. So I think it's potentially going to discourage people from doing those types of cases because of that.
Don, I see you're on the call there. Salsa, what do you think?
Why are you calling on me?
I don't know. I just kind of went through the list and I saw you, and you're usually pretty opinionated. So I figured you'd have some good thoughts on this.
Yeah, obviously. I mean, I was part of the team that generated these codes and produced the codes, and all we can do is use the data that the surgeons who answered the surveys provided us. And the reality is that surgeons tend to overestimate their surgical prowess and underestimate the amount of work that it takes to do a surgical procedure. And as a result, when you look at the amount of time that they said it would take to do certain hernia repairs, it basically means that the average surgeon, maybe not surgeons at Cleveland, or maybe not surgeons in certain parts of the country, but the average surgeon is, for an umbilical hernia, is doing a ventral light mesh that they tuck in the preperitoneal space. That's what they do. And it takes them 30 minutes. They don't do a robotic E-tep. And that's the end result. Now, the bigger hernia repairs obviously are being done differently. And if you're not doing a component separation with it, then the time actually starts to make sense. And just remember that you know, the care that we used to get credit for those codes also included postoperative care. And so that's why the values were higher for some of those hernias. And so the end result is that you get less of a value. And I know surgeons have a tough time understanding that, but that's how globals work. All of the work that you do is baked into those globals. So.
Excuse me, Ben.
Hey, so this
At
is
Ohio State, you're running a department, Ben, at Ohio State You guys, you got to be productive. There's a bottom line. How are you going to respond to this?
Yeah, it's well, I can tell you, especially with the increased number of ambulatory surgery centers, we had just opened up our second ASC and now our third ASC is coming online. It's pretty clear. I mean, the expenditures associated with one approach versus another really kind of get magnified. So yeah, if you're taking 3 hours, 2.5, 3 hours to do to repair a 2-3 centimeter hernia that you could do much quicker, it's pretty clear what the answer is going to be. The interesting thing is, I have 2 quick comments. The first is the continued race for surgeons to say they do things in less and less amount of time is directly proportional to the continued decrease in payments that we're all receiving from a professional standpoint. It's like, as Don mentioned, we're like famous for this for years and years. If you ask one of our GI colleagues how long it takes them to do the colonoscopy, like, whoa, hold on. You got to look at every little fold. You got to go through the entire colon. It takes at least 35, 40 minutes. Again, just kind of food for thought in terms of how we sell ourselves. The other thing I'll throw into this mix is, all right, Mike, so let's say that, if you're a surgeon, you realize, okay, now I'm getting paid, a little bit less. It's largely going to be based on size. What if you're doing the 3 centimeter ventral hernia, doing a robotic or lap ETEP for that matter, and you bill for a myofascial flap with myofascial release, let's just say 14301, which is, our data says that you should be able to do that. I think this is going to push more people to go for that CPT code in terms of the 14301 for the ETEPs.
Yeah, I think that's a reasonable thing. I think in our paper, I think we said if it's 3 centimeters or less, don't use this code. If it's over 3, do. So I don't think it will fix the small ones. I think that's one solution. I mean, ultimately, to that specific thing, I think that's a fair use of the code. Whether or not you get it paid, whether it gets denied, whether it puts you in this endless cycle, like time will tell. But I always like to say, like, I really think, and this is people who are watching this on demand or hear people speak up about this, I think most surgeons, most general surgeons in the real world are just trying to do what's best for patients and don't think about how long it takes them and don't think about a lot of other things. They look to kind of leaders in surgery and just say, hey, like, what do I do to take good care of my patients? If it's going to take me longer to do an ETEP and that's best, I'll do it. And I appreciate Megan kind of going through this literature, because I think that we have kind of let ourselves become derailed by over complicating the algorithm for hernia surgery. And I, again, not to single any one group out, but the reality is the people who undoubtedly benefit from an excessively complex algorithm and multitude of minimally invasive surgical approaches is the one robot company right now, because a lot of this stuff can't be done laparoscopically. So I think we just have to kind of recognize the ambiguity and uncertainty, accept that this is not fact. And I like my message to be for people out in the real world, hey, look, if you do a good lap, quite frankly, if you do a good little preperitoneal, umbilical hernia repair, you're fine. Your patients are getting good outcomes. You're doing a good operation. You should not be forced to kind of go through this horrible learning curve for small hernias. Now, more complex things and whatnot, the data is not there yet. But I think this kind of reiterates that, and I actually, whether you're a robotic IPOM, a lap IPOM, like, to me, that's kind of dealer's choice. It's just the plane you're in and the tools that you have. And if you have access to a robot, good for you. And if you don't, and it's hard to get, you should feel comfortable doing a lap IPOM. But I think, the message in the background of all these billing changes should be crystal clear to surgeons. Luciano, you want to do your, any other comments?
Yeah, feel free to put anything in the chat if you guys have any additional question. I think Aldo, did you want to?
Hey, can I make one comment, Mike?
Of course.
So there was no ulterior motive to reducing the value for hernia repairs. If you listen to, and if you read the communities on the American College of Surgeons website, hernia has changed over the last 20 years. The last time hernia repairs, the values were generated is when hernias were being done exclusively as an inpatient setting. And so surgeons are now doing hernia repairs routinely at ASCs. And the reason that this happened is because the open incisional hernia repair code no longer was being performed the majority of the time at an inpatient facility. It was being performed at an ASC. And Medicare is not going to pay for postoperative care that includes inpatient stays when they find that the location of service has changed. So the values of hernia repairs and how hernia repairs have been done over the last 20 years, the values and what we're doing have changed. And so our goal was to actually protect value, hoping that surgeons that did it robotically would answer and give a nice long duration of a surgical procedure, but that's not what happened. And so the real challenge is, and I hate to say this for all of the trainees who are on this, surgeons are felt to be overpaid. Primary care is felt to be the area that the investment needs to take place in our country. So there's no concern about the reduction in the conversion factor and how it impacts the values of surgeries. And yes, we should still obviously take care of patients and do the best we can. But surgical reimbursement and surgical salaries are not going up. That's not, that day is, that ship has sailed. And trying to complain about it in modern healthcare, unfortunately, will only make things worse, because it now you look like you're insensitive to what the rest of the country feels is the major need.
Well, I completely agree. I thank you. And it's interesting. I do look at those ACS communities every day. I'm on the general surgery, MIS, rural surgery, and I think maybe one other one. And the vitriol is real. I would not say that their interpretation supports that, but I'm sympathetic to what you're saying. But I think that there is a disconnect amongst the reality of what's happening and what surgeons think their role is in preventing some of these things from happening. So yeah, I mean, it's a tough lesson.
Okay,
All right.
let's move on to the.
Aldo.
Go
All right,
ahead, Aldo.
all right, let me share the screen. Everyone see my screen? It's
Yeah,
two cases, and we'll try to move them through quickly in the 15 minutes that's left. Hopefully we can generate some discussion. So the first case, it's a 28-year-old male. He comes to a clinic. He's got a supraumbilical and epigastric hernias, both primary. He's got no prior surgeries, no past medical history. He presented with his burning pain. His BMI is 27, and his hobby is he's a bodybuilder, so he lifts heavy weights. So, Luciano or Sergio, what's your go-to approach in Texas for this guy?
I think that probably here with small supraumbilical and epigastric hernias, he would get a robotic TAPP with uncoated mesh.
Okay.
How big is the umbilical? Aldo?
Umbilical, it's 2 centimeters. The epigastric one, it's about 1 centimeter. They're a couple centimeters apart.
Yeah, I think that currently here, at least in our institution, that's what he would get.
So a robotic ETAP?
No, a robotic preperitoneal repair.
Oh,
TAPP.
prepared. TAPP.
Yes. So usually with no type of fixation, just create a preperitoneal pocket and put a piece of uncoated mesh in there. And then suture the peritoneal with some barbed suture.
Any other opinions or how you would fix this guy?
That was the background sound of Cleveland when Luciano said that. Like you could actually hear the hysterical crying in Cleveland when Luciano like said what happens in Texas. It's amazing that I was muted, but you could hear me. There I am again.
That was
It's
my
like
kid.
both things.
That was my kid. He was just saying, "What you're talking about?"
Even he knows he's just a kid.
But I do agree with Don. What exactly Don said. I think that the bulk of the average surgeons for this patient, they would probably do a ventrolite patch match. And I think that for the majority of the general surgeons who are not like MIS or like ab wall specialists or anything like that, I think that's probably what they would do.
Yeah, that's so true. When we rotate in our community sites, there's general surgeons who preperitoneal approach is their go-to for these types of hernias. They don't even think about laparoscopic. They don't do robotic. This is their go-to operation. They do a great operation, and that's their the main way of doing it. So, of course, we're in Cleveland Clinic. So we discussed primary versus mesh repair. And patient, because he lifts heavy weights, he's a bodybuilder, he requested mesh. So we offered him a laparoscopic IPOM. A 12 centimeter ventrolite ST mesh was placed. The Protect device was used in a double crown technique. The procedure was straightforward. There was no complications. He was sent home on the after the procedure that same day. He comes in post-op day 11, is presenting with severe abdominal pain, nausea. The vitals are as shown here, is mildly tachycardic. The abdomen is soft, mildly distended, diffusely tender to palpation with worse pain in the epigastric region. We got a CAT scan. I'll just play it slowly. And please jump in if you see anything abnormal.
He's got a bowel obstruction.
All right. Hey, Jesse, anything else you see?
I mean, he's got a little bit of fluid. I mean, the next thing I would see would be in the operating room for this.
What's happening to that one tack? Is there like one tack that's sort of in the
Yeah.
middle?
Yeah.
So exactly. So it looks like he's had a dislodged tack. And if you play it, there seems to be a little bit of a swirl, and I'll play it quicker because it's easier to see here in this region. So as Dr. Rosen said, he's got, the official read is a small bowel obstruction with potential 2 transition point concern for closed loop. So he's taken to the operating room. And what was found is there were several tacks that were not incorporated into the abdominal wall, causing several loops of small bowel to be attached to the tacks. And on this picture here on the left, you can see that dislodged tack. And unfortunately, the sigmoid colon was attached to this tack, and it was causing the small bowel to valvulize in an internal hernia fashion. All right, Sam, what would you do?
So we're in the OR at this point. I would take the tacks out. I would inspect the bowel closely, and if there are any full thickness holes, then probably convert to open to repair or resect.
Good. So fortunately, the tack was able to be removed the dislodged tag. The bowel was inspected. The bowel wasn't injured. There wasn't even a serosal injury. The loose piece of mesh here that wasn't tagged properly was able to be tacked with an absorb-a-tack. So the procedure was never converted to open, thankfully. So they stayed laparoscopic, and post-op, patient was admitted. He had an NG, but then he continues to have pain, and he's concerned the mesh and the tacks are causing his current pain. What do you do now?
Well, wait, Aldo, can I ask you a quick question?
Yeah.
Like, what's to blame there? Like that first complication, like what's the problem? What
This
happened?
is a technical issue. So this is a technical issue with the tacker. Looking at the op report, I think when those tacks were placed, obviously you have to do the counter intention. You have to feel the tip of the tacker, and you have to make sure that all those tacks are fully incorporating the mesh into the abdominal wall, and there is no tag that it's being exposed. And also, obviously, that the dislodged tack was causing the majority of the problem, and that was missed in the operation. I'm not sure.
First of all,
Actually, I don't know if the tack fell afterwards or he was misfired and just.
I mean, first of all, I think this is part of the operation. The truth is we don't do as many IPOMs as we used to, so people can kind of get lackadaisical about putting in tacks, and like those tacks are bullets, basically, right?
Yeah.
So if you shoot somebody, it's not the bullet's fault; it's the person who pulled the trigger's fault, usually. And so, I would just say this is a common thing when I watch people. Like, those tacks are 3.8 millimeters in thickness. And an appropriately placed tack, you should just see kind of one of the tines through the mesh. And if you're not putting them in deep and they're kind of halfway through, that's kind of where the sharp ends can start to stick out, and they're not free. You can really hurt people with tacks. That's a necessity for IPOM. Probably fair to say like a weakness of IPOM that requires like meticulous technique, just like onlay requires appropriate blood supply, whatever, and retromuscular requires. So an IPOM still can hurt people, and you can still have technical issues. But I think that the placement of those tacks, and it's interesting. Somebody put something in the chat. If you do an IPOM like what Megan showed, where you're only using 3 ports, one side is typically tacked reverse camera, and that can be challenging. And I mean, Ben even brought that up. So if you're reverse camera, like, you've got to be skilled to be able to do that. And if not, just put another 5 so you can go in line with the camera and make sure that those tacks are depressed, because being reverse camera, getting 90 degrees is hard.
Any preference with regards to pro tags versus absorb-a-tack for the experts in the call?
I mean, there's several absorbable fixation devices beyond just absorb-a-tack. I think there's no studies that have really ever shown one better than the other than I believe there's a study from the Netherlands that looked at long-term in a large database. And if you only use tacks and you do a double crown, the recurrence rate is higher if you use an absorbable fixation device versus a permanent fixation in tack only double crown technique. So our group, we use permanent fixation. I'm sure other people do just fine with the absorbable fixation. I think it probably is more important that you put them in right than what it is.
I mean, I think to Mike's point, it's about the technique. If you can have the same issue robotically when you're suturing with the barbed suture, if you don't cut it flush and you leave, a little tab of the barbed suture out, that can cause a bowel obstruction too. So whether you use a tacker or suture, you have to make sure it's kind of flush with the mesh in the abdominal wall. I think the technique is the same regardless of approach.
Okay, so maybe we should have done the robotic TAPP, right?
Luciano's kid is having a friggin' nightmare about it.
All right, so with that, we'll move into the next case. So you have a similarly aged gentleman, 32-year-old male. Now he presents with only umbilical hernia. It's about 1 centimeter in size. Again, he does a lot of heavy lifting at work. Again, no past medical history, no operations. His BMI is slightly higher, it's 31. Any difference in opinion? Anything someone would do differently in this gentleman?
You said the defect's only 1 centimeter. I would just do a primary repair with suture open.
I'd push him to do that. I would have done the last guy primary repair too, just for the record. I think all these
Primary.
small ones, I just offer primary repair usually. A BMI 31, honestly, might make me think about putting in mesh there, and I mean, as Aldo said, our guys at Hillcrest, our community hospitals are phenomenal at putting those little preperitoneal patches. I just find that hard. So if I put mesh in them, I do what Megan showed. But it's probably a little bit overkill. Like I won't deny that.
Luciana, did you have a comment?
Yes, I want to ask if anyone would change their management if the patient has an associated diastasis. Let's say this guy, which we're assuming that we're going to do a primary repair, but he has an associated diastasis. Would anyone use mesh because of that? Would anyone be concerned about an increased recurrence risk because of the diastasis? Because I see a lot of the associated diastasis can be used as a push to do more advanced operations or to increase your coverage because of a concern for increased risk for recurrence because of the diastasis.
I mean, I wouldn't, not at his young age, and no, and the small size of the hernia. I don't think it's worth making this small hernia a bigger operation for him at that age.
Since the advent of robotic hernia repair, I liken the diastasis to almost like at the same level as like pancreatic cancer, metastatic melanoma, absolute destruction of people's lives. How do you go on living with the diastasis? It's like ridiculous. Like, I mean, it's like if there was a biliary dyskinesia of the abdominal wall, diastasis is it. So I mean, listen, I just tell these people, God made a bulge up there, can't fix that. We'll take care of the hole. You're still gonna have the bulge, and I'd think about again like a BMI of 31. Like just for the reality, just to be clear, BMIs of 27 and 25 typically don't get 2 centimeter umbilical hernias. They get like 1 centimeter. People in their BMIs of 30s, like they're usually the more like the 1.5 to 2 centimeter umbilicals. So like I might be a little bit more prone to thinking about mesh in those, but I agree. I was glad to hear Randy said that. I think the data is clear. There's a 90% chance of success with primary repair. Like, why not try that the first time? And then if it doesn't work, do whatever your fancy operation is. But I mean, I would always take that chance. And
but I don't feel like being in clinic, I don't feel like we present it that way at least most of the times to the patient. We don't say you have a 90% chance that this is not going to come back if we fix it primarily.
Well, Megan, what do I say in clinic for a small umbilical hernia?
That's what I say. I say 5 to 10% chance of recurrence.
I mean, there's that large trial that's from England that really showed, like, again, this is actually, to me, is probably the most misinterpreted trial ever done, because it was a 12% recurrence rate without mesh and like a 5 or 4% with mesh. And that was statistically significant. So they said everybody needed mesh. But I interpret that to mean 88% of small umbilical hernias are just fine without mesh. So like, why not try that and save mesh for the recurrent ones? And then I don't mess around. Like I wouldn't do 5 primary repairs, but I try and counsel young, thin people, just take the stitches the first time. We can always come back with mesh.
And you said you'd consider mesh with this patient. What's your approach? Where would you place that mesh?
Me, I would do that. Like this would be the procedure that Megan showed. I would do a little incision in the belly button. I would do an IPOM.
Okay.
Just because I'm not good at those ventral X patches personally.
Okay, again, so we discussed the primary repair versus mesh. The patient, again, because of the heavy lifting, requested mesh. And I failed to mention that we also had a robotic ETEP versus IPOM trial going on. So the patient was enrolled in the trial. He was randomized to a robotic ETEP. The procedure went well. There's no complication. 15 centimeter long by 20 centimeter wide pocket was created with a similarly sized mesh. The patient went home the same day. There was no fixation. There was no drain. He comes in clinic post-op day 6 with right lower quadrant pain. His pain was a little bit too much to be expected at post-op day 6, so he was sent to the emergency department. He was slightly tachycardic on 109. The rest of the vitals are shown, unremarkable. His abdomen was distended, and again, on palpation, he has some right lower quadrant tenderness. His white count was 18, and lactate was 2.3. Of course, we have a CT scan, and slow it down here. Let me know if you see anything abnormal in this CAT scan.
What post-op day is this?
6.
Go down a little bit. There's a little bit of fluid. It looks like in the retromuscular space extending up into the umbilicus.
He's got some hair there too.
Yeah.
This is
Subcutaneous
bad.
hair.
Well, the read is just small bowel enteritis with thickened small bowel and some mesenteric fat stranding.
I bet there is small bowel enteritis.
So the patient gets admitted to the hospital. He was started on antibiotics and was observed, but he continues to have abdominal pain. Do you have any concerns at this point?
Do you have a missed enterotomy from the kind of like what Megan was talking about with the posterior sheath, because you can't see what's, intraperitoneal? That's what I would be worried about.
Okay. All right.
This is so important to bring that up, because I think this is how people die from a small operation, is that and again, anybody watching this who's learning on ETEPs and whatnot, this is where you're like, I was never in the belly. Everything's going to be okay. And this is where people that don't look right on post-op day 6 after minimally invasive hernia repairs, something is wrong. And you got to go figure it out. I mean, again, this could happen open, lap, robotic, ETEP, iPod, it doesn't matter. But when people get sick and they have fluid in air, if you sit tight, people die from this stuff. So yeah, to me, I mean, it's low threshold to just take a look, at least put a laparoscope in. You will never regret that, going back and looking. These little cases are kind of like gallbladders. If a gallbladder comes back, something is wrong. Evaluate.
Yeah, but both of you hit the nail on the head. So the patient was taken to the operating room because of those reasons you mentioned. So intra-op, the mentum, there were several loops of bowel. Had a mentum stuck anteriorly. And after everything was taken down, there was a small area of the posterior sheath that appeared to have been cauterized. Underneath this posterior sheath cauterized area, there's a loop of indurated bowel that a tiny walled off enterotomy. What do you do now? Was contained, there's no succus, there's no fluid, everything seemed to be walled off. Do you close the enterotomy? Do you resect it?
I think this many days out probably would require a resection, and likely that mesh has to come out.
Yeah, I mean, I think this scenario, you have to move away from thinking too much about the hernia and thinking about saving people's lives and preventing fistulas and stuff. So luckily it was a small hernia to start with. So if it was me, I'd just take it out, do whatever we have to do to the bowel, take out all the mesh, close primarily. And sometimes you lose, and it's okay. And then you can fix this guy 6 months to a year from now in whatever way, if it's small, maybe something MIS, and if it's something big, then you got to go back and do something big. But I would get off the worry about hernia stuff and get on the worry about fistulas, mesh infections, and all the badness, and just sometimes take your best shot and you lose.
Yeah, so that's exactly what was done. So the procedure was converted to a mini laparotomy. The bowel was that segment was resected. There was an anastomose with the staple, and the whole mesh was explanted, and the defect was closed primarily.
How you gonna fix him next year, Aldo? He comes back with like a 6 centimeter hernia.
He hasn't come
That
back
plane has
yet.
already been burnt. Should we ask Luciano's son? He'd be like, RTAP, no! Don't do it, Dad. What
He
are you
went
gonna do
to
next
he
year?
went to sleep after that one.
That's it. He's like, Dad, I can't even watch this anymore. This is so bad. Take me back to Cleveland. So what are you gonna do when he comes back with a 6-7 centimeter hernia?
And it's reducible. He has just pain.
Yep.
Provided the BMI is still, high. Again, I would offer him most likely, another retrorectus repair. If I can get away with it, and while I'm intra-op, it might require a little bit of a release to get the.
Well, but you've already done the retrorectus dissection. So like, what's the chances this is just going to be retrorectus? It starts with a 0 and it ends with a 0. I'll let you guess.
Yeah.
No decimals.
Yeah.
I mean, I think like I only bring this up because listen, when IPOMs were all over the place, we saw a ton of IPOM failures and we learned how to deal with them. Now that ETAP is everywhere, we're learning how to deal with ETAP failures, and we're seeing a lot of those. So, and same thing for TARs. Now that TAR is taking off, we're seeing a lot of TAR failures. So when people dissect this ETAP space, it's much, much more difficult because it's retracted and you lose a lot of space. So like this guy's going to need a TAR no matter what. Like, you committed him to a TAR. That's one of the downsides. You started with a 1 centimeter umbilical hernia, you're ending up with a TAR. I mean, like, it doesn't feel good, but that is the consequences of complications from these operations.
That's crazy. When I was going through the literature, the one thing that came to my mind is that surgeons are going to do what they're good at, not what's good for the patients, which is sometimes unfortunate.
Or, I mean, in fairness, or they're going to do what they think is best for the patients. And that message often doesn't come from, thorough evaluation of the literature. It comes from kind of expert opinion and personal bias, which, again, I mean, like a lot of things in life come from that. That's not all negative. It's just recognize that some people were learning about this stuff as it goes. So although it can sound authoritative, that, look, I mean, ETAP, like you said it yourself, like ETAP is cool. Like, I get it. I come in and I watch guys do it and I'm like, oh, that's neat. That's neat. It looks like fun. Like I don't deny any of that. It's fun to do cool MIS things, but I think like as it picks up and we learn about it, all of a sudden we see these complications that like are horrifying and they're often not reported in the literature. And so this is how we learn about things. And so again, it's not to say that everybody needs an IPOM and nobody should get an ETAP. That's obviously not true. Before we get off, I just want to throw this out there. Nobody should get an RTAP. That operation doesn't make any sense. You're dissecting off a devascularized thin layer of peritoneum instead of putting a piece of mesh that is engineered to prevent adhesions. So that operation, you completely lost it. And so that makes no sense to me. The ETAP, I think it actually has some roles, and you kind of highlighted it well. But the RTAP, complete waste of time. Just do an IPOM and move on with your life. Do it robotically, do it laparoscopically, it doesn't matter. But the RTAP is silly. So okay, that's the end of my diatribe. It's getting late though. Should we
Yeah, we'll wrap it up. All right. Thank you, Aldo. Thank you, Dr. Higgins. Thank you, everyone, for attending. Next month, we have one more sort of monthly webinar on January 9th. And then after that, we're going to prolong the time period out to quarterly. So next month, we're going to talk about robotic approaches to ventral hernia repair. So thanks for joining.
Thanks, everybody. Have a
Thanks,
great
everybody.
new
Great job,
year. Happy
Megan.
holidays. Take care.
Take
Be
care.
safe.